please write. I use that as a backdrop introducing Dr. A.T. Pollack, who is an obstetrician, gynecologist, graduated from medical school at the University of Florida, and Dr. Pollack has enormous experience in domestic and international health. For over 15 years, she served as a medical officer and as the CEO of EngenderHealth, which is an international nonprofit that specializes in women's health services and in the relationship and in the introduction of new technology in low-resource environments. EngenderHealth, Amy tells me, at one time or another, has worked in over 90 countries, 9 total. More recently, Dr. Pollack was a vice president and chief medical officer at Adiana, a women's health medical device corporation. Dr. Pollack is well published, has been an advisor to USAID, US FDA, NIH, World Bank, WHO, and ACOG, and many other organizations. Dr. Pollack joins us from New York, and please join me in welcoming Amy.
So it's a pleasure to be here. I'm really excited to be back again. I did a talk a couple years ago, I think, before you had a joint program in the medical ethics seminars.
Actually, before we had a global health program.
Right. And really enjoyed that. And I know that you've had a roster of really remarkable speakers. So I hope I can keep up with their presentations here. Months ago, when Mark asked me to participate in this, he asked me specifically to talk to you about EngenderHealth, partly because it is a very kind of classic non-governmental organization, and it represents a piece of the pie in all of the global health arena. And so if nothing else, you should come away with some understanding about where it fits in and what kind of work it does, however representative of the kinds of work that some of the other large nonprofits, non-governmental organizations, and we'll get back to that in a minute, that are around. And you can think about care on a much larger scale. They have a much broader mission. Save the Children. There are organizations called Pathfinder, the Pop Council. There are a whole host of these, what we call NGOs, or non-governmental organizations. And so I had the privilege of finishing medical school and studying to be an obstetrician gynecologist. I had always intended on going into public health. I never really had an interest in practicing straightforward clinical medicine. I then got an MPH right after that and got board certified. And so took off right after that for New York to start working in the international healthcare environment through the nonprofit sector. And came across an organization called AVSC. And that was the Association of Voluntary Surgical Contraception. So you'll see how that fits into all this in a minute, but my route there was through regular traditional training channels, and this was long before there were programs in global health. There really weren't any. So my MPH was really in epidemiology and health services combined. I did that in Seattle, where I did my OBGYN training. So I'm going to tell you, let's see if I can manage two of these at once. I'm going to tell you specifically today about EngenderHealth, who it is, what kind of work it does, how it does that work, which is different than what work it does, what are the constraints on it, what makes it do that kind of work, and when. And then I'm going to try, if we have time, to focus on two kind of mini case studies on issues that were tackled by the organization during my tenure there in a leadership position. So first of all, EngenderHealth is a nonprofit organization. It's headquartered in New York, so it's a 501c3, which means it's incorporated in the U.S. and has nonprofit status. That has constraints already attached to it. But we worked almost exclusively internationally, although occupied some space in the health community in the U.S. and in our areas of expertise, which were originally in male and female sterilization. So EngenderHealth is about 65 years old, a little more now. It began as a very small local volunteer association, as these organizations often do. And it advocated for, which meant on a policy level, it worked towards safe and legal sterilization in the U.S. at a time when there really were not many options for contraception, and sterilization was very controlled in the hospitals by physicians who had the authority to either approve or not approve a woman's sterilization, and male sterilization was not readily available. So the founders, one of them a physician, worked hard towards legalizing this and then towards assuring that there were informed choice regulations. Some of you may remember that there were issues around sterilization long ago in the U.S. when women with deficiencies in one area or another were considered inappropriate for childbearing, and so somebody would make a decision to sterilize them. And so they worked hard to actually formalize those regulations. So the nonprofit is based on now high-quality clinic-based services, client-centered reproductive health services, and working now in the poorest countries. And this evolved from the origination and the original incorporation in 1943, which was pre-legalization of contraception in general, which happened actually in the 60s. Then the advent and introduction of hormonal contraception followed after that. In 1973, the U.S. government then took on the role of, in foreign assistance, of helping countries to be more proactive about limiting their population growth. It was really called a population control program, and that's old language. And AVSC at the time was considered the expert in assuring informed choice and quality surgical services for those programs. So it expanded rapidly in the early 70s because it got larger government grants than anything it had ever seen before. By the 1980s, it had expanded its focus to all of the long-acting contraceptive methods. So that meant clinic-based services. So now, by the 1980s, AVSC was an organization that clearly did service implementation instead of research, like the Population Council. If any of you know who they are, they do research. There are other organizations that do gifts in kind, where they distribute food that's donated or not necessarily in the role of providing health services. Our expertise became clinic-based services. So contraceptives like hormonal contraceptives delivered pills, basically, went into the marketplace directly. But if you needed an IUD placed or later on Norplant placed or a surgical method, then we were the ones who cleaned up the surgical services and provided oversight as an implementing agency. And so there's an important distinction first in what you do as a nonprofit, and then a subgroup in the clinic-based methods and then clinic-based services. Today, you know, we went through several changes after the Cairo meetings. Some of you may know about the ICPD in 1994, where there was a huge civil society movement and pressure directed immediately at the UN, but coming from civil society, meaning all of the society that has volunteered to exist and should not be constrained by government. Their voices and advocacy were for seeing women as more than a reproductive instrument. And so they wanted to mesh certain kinds of women's health services with family planning services so that women didn't stand alone and go to an isolated family planning clinic as opposed to a health care clinic. And at that point, we added everything that was involved in women's health in clinics and in operating rooms. So we started work on maternity care and some of the child health issues where the only access to those children is through a maternity care service. We added post-abortion care. We had reasons for not adding abortion care at that time because of the U.S. government policies, and I'll explain how that works later on in the talk. And ultimately, adding HIV and AIDS. So in 2001, we changed our name. While I was there, we rebranded to EngenderHealth, and that name has served the organization well this far because a big part of what has changed in the environment is a newer focus on gender equity and health equity, and so we came in under that movement and are now kind of sitting well in it because it's trying to combine gender issues with the clinical safety and efficacy of delivery issues and trying to understand now men's role in that on an advocacy and political and social platform. So it's kind of a natural progression, but it has different ways of looking at it. All nonprofits have a mission statement. The mission statement should be what all of the employees know and understand to be their vision, where they're going, how they make their decisions, and what guides the organization in terms of its values and how it works. And so EngenderHealth's mission involves health, poorest communities, sexual and reproductive health, quality of health care, gender equity, rights, and most importantly, partnerships on the ground with our colleagues there who are working to develop capacity locally instead of dependency on foreign assistance. Just as a practical overview, the organization is quite large. There's a president who provides the leadership and the vision for the organization, but in collaboration with a board of directors that's always a volunteer board in a nonprofit, and so the work that you get out of your board is not like the work you get out of a company, a for-profit company. They volunteer their time and effort, and often the nonprofit is really responsible fiscally and otherwise for everything it does with just board oversight, and that is changing now, but it used to be a very, very kind of lightweight oversight. We have programs, and within the title of program, we have not only content areas but different kinds of initiatives that we take on, special initiatives, and technical support, including monitoring and evaluation, which kind of guides us through looking at our outcomes at the end of the year and figuring out what we got done and how well we did it. There's a whole group of organization development and human resources infrastructure. The operations of the organization, always critically important, especially for an international organization, because of the kind of oversight that you need when your offices are not in your backyard, and it's very difficult to do, and is limited financially by your donors, the amount of money that you can invest in that kind of oversight. And then there are external relations, which is how we do our fundraising, communications, and marketing, and even advocacy, how we get our messages out. EngenderHealth currently has 540 staff globally. We have so many staff in part because what we do is deliver services globally, and so it's an actual service piece. It's a bit like manufacturing. You have to have people employed to do that. Otherwise, nonprofits often work on with a much smaller employee base to get their work done because of the cost of doing business. We have been on a trajectory that has increased annually. It increased dramatically during the time that I was there running the organization, and since then has continued the climb to increase. And part of that has to do with the increasing visibility of global health. It also has to do with the depth and breadth of the services that we deliver. And frankly, it has to do with the private donor environment, in particular the Gates Foundation, which, when you have a large budget, can really, you really need a large donor to make an impact on that. And so that has changed our landscape completely and everyone else's during the last 5 years in particular. Currently, EngenderHealth has formal offices in 13 countries and programmatic area, activities in 21 countries. But it's important to understand, once you reach a certain size as a nonprofit working internationally, and you have a reputation for doing certain things well, then you can add one grant for $20 million in a year, and that can change the number of offices and the number of staff you have dramatically. And so some of the challenge of running something like this is that the grants are usually a year, 3 years, or 5 years long. And how do you manage that number of staff? How do you staff up to manage a large project and then staff back? What do you do with the staff once the project ends? It's a little heartbreaking when you're in Lagos and you have 40 staff for 3 years and then you have to let 20 of them go. So you deal with all kinds of trials and tribulations that come with getting grant money that comes on and off, even more so if the grants are large and not for a very long duration. The ideal grant would be a 10-year grant that's very large and has built in some kind of cost recovery mechanism so that you're building some sustainability on the ground so that when you leave, those people will still have jobs and you will have done your job and left. But grant makers don't always see it that way. The current programs in EngenderHealth are focused in Africa, where most of the money is for doing work in HIV/AIDS and maternal health. Some in Asia. We used to have very large Latin American countries, but many of those countries have graduated from foreign assistance, and so we're only there if we have a private donor that's really invested in a specific kind of program. And this gives you a little picture of the finances, which is really important in terms of looking at the scope of a nonprofit organization. The circle, let's see if I can get this. The circle here is really, what we do with our money, and that's fine. That is actually kind of predictable because we're really not allowed to spend much more of our money than this on administration. And that is based on how much money we get from the U.S. government, who negotiates a rate with us. And so once they negotiate a 14 or 15% overhead rate, you can't really change it very easily. In fact, it's almost impossible to get meetings with them to change it. And so you're stuck with it, and their requirement is that you use that rate with your other donors. They can give you less, but they can't you can't charge them more. So the U.S. government prides itself on determining this rate, and it doesn't really matter how much money you get from the U.S. government. We happen to get a lot now, but it could have been a lot less than that. It's just it takes up a piece of what you negotiate to get any money, and you're stuck with it once you get it. In this case, in this budget, and this is, I think, a 2008 slide, the U.S. Agency for International Development was responsible for $47 million out of a $92 million budget. And so they have a lot of power. And when we talk about individual and institutional contributions, some of that is actually U.S. dollars through Pepfar or through other venues that are not managed by USAID. So there are other foreign assistance pieces in the U.S. government that distribute funds. And indeed, a lot of this individual money is the Gates Foundation or Buffett, Hewlett Packard, all the typical ones, predictable ones that are involved in reproductive health in particular. So we don't, the organization really is more reproductive health than HIV/AIDS, but the HIV/AIDS money is applicable in a reproductive health setting. So that was a transformation that occurred a couple of years ago where there began to be some crossover. A lot of donors don't do crossover well. They want to know that their dollars are going specifically to HIV/AIDS program, and they don't want it even in the same arena as the reproductive health program. And so when you start hearing about integration, healthcare integration of programs, what we're talking about is, it's a little bit like a higher level of the Cairo agenda. They wanted to go from family planning to reproductive health. The next step was reproductive health to integration to health, that there's no good argument to separate it out. And some people would argue that for women there actually is a good reason, because some of the reproductive health money gets swept away into programs that mix and match. And it's no different than some of the earmarking arguments here in the US in the federal budget when we're discussing it. So everybody has their ideas about how they want their money, used. These, the other non-US government grants, contracts, and miscellaneous income account for some great money for the organization, some of it unrestricted. That means money that's not marked to go to a very specific program. And that money is flexible and usable to discover new things, to try new things, to do some integration in a place where no donor will pay for it. And the two programs I'm going to talk about at the end of the talk represent programs that were done with seed funding and unrestricted grants. And that money is really the most important money for a nonprofit. Okay, so what's the work of EngenderHealth today? Let's see if I can, just give me 1 minute here. I've lost my... This is a picture of a slum in South Africa, right outside of Cape Town, where we had a big project working in one specific area. And I think they patched the picture together because they couldn't get the scope there. You can see the line that goes through the photo. It was such an amazing picture to me. This went on and on and on forever. Incredible slum. So the work that EngenderHealth does is focused, as I said, on sexual and reproductive health. That includes clinical content areas that are family planning, safe motherhood, and HIV and AIDS, but also cross-cutting technical areas, which has more to do with kind of how we do our work in terms of measuring our own work as an outcome. It's quality improvement, integration approaches, as I mentioned, Gender and a Menace Partners program. This is a program that tries to look at and bring in different interventions, community interventions that engage boys and young men, either in basically in taking on responsibility. And there's a huge amount of work going on in this area, but it was an area that we worked in early on because we had expertise in vasectomy. And even though vasectomy is an adult service, it involves men, and we were really the only ones working closely with a completely male population in a clinic base. And so it kind of led to a Menace Partners program for which we've had, now have developed whole curriculums. This was a big piece of our Latin America work and is now widespread in Africa as we try to get men to join in the fight against AIDS instead of leaving kind of women in the hospital with maternal to child transmission prevention or other aspects of caretaking, condoms basically. And community engagement. As I mentioned, the whole goal of the work of an international nonprofit, unless you are missionary driven, and by that I mean driven to do good but not necessarily to build capacity. The whole opposite of that piece is building capacity, is not putting a lot of expats on the ground, but really training up the local staff and community to own the clinic, to make the improvements in the clinic that they need, to want to make the improvements and train to do different things, and to look at their outcomes more carefully. And so some of it is just training in problem solving. And a big piece of the quality improvement work we do is teaching clinic and hospital staff to do their own problem solving around infections, infectious transmissions, outcomes that we measure for them and help them learn how to measure. So when you talk to a donor, the donor really wants to know what your distinctive competencies are, what makes you as a nonprofit different than your neighbor. And so some of the things that we do that EngenderHealth does that they consider kind of their competencies are issues around scaling up contraceptives and appropriate technologies. And this is where introducing technologies comes into play. One of the things that we have done is looked with seed money at early stage technologies that are already utilized. We're not looking to get them registered or to do the R&D associated with them, but we're basically looking at a demonstration project to show that a technology can be used in this environment safely and effectively. And there are other organizations that do the R&D around a new technology. Developing clinical skills and measuring provider performance, ensuring voluntary and informed decision-making, a big piece of the contraceptive milieu, and also in HIV and AIDS work. Using rights-based approaches, and this is kind of new terminology in the last couple of years, but basically designing programs that really respect the decision-making of the client and really mesh with an informed choice kind of framework. And then developing and adapting service delivery guidelines so that working with WHO or the UN to standardize care, to minimize cost and maximize the outcomes for communities, and to adjust them and adapt them to their own particular community need. We measure for continuous quality the same way that we do in our hospitals and clinics here. I mentioned building capacity, gender equity, involving communities, and policy advocacy, which is something that we don't do as a core strength and competence. We're not an advocacy organization. We don't lobby, and we don't pride ourselves on interfacing that intimately with government policy. But we do policy advocacy at a local level to help the community advocate for what they need in their community, in their clinics. Now, it all sounds kind of very organized and straightforward, but in fact, what determines who EngenderHealth is and what they do is kind of a whole variety of what's happening in the environment today, what happened yesterday and where they came from, and what they anticipate to happen tomorrow. And the better, not unlike with a for-profit company, the more vision you have, and the more correct that vision is, the easier it is to get your work done the right way without having to lose a lot of staff once you hire them, which is painful, or close clinics, or get into battles with the government, or even your own. So you have to anticipate. Part of it is looking into the future. So you depend on a board that has good diversity in it, that can see around the issues and understand what you're doing, and can help you with your strategy. You always look to your mission to make sure that you're on target and you're not swaying too far from your mission. And there are some hard choices that you have to make because funding and mission kind of sometimes clash when some donor is offering you a huge amount of money to do something that's not quite on your mission or not quite according to your values. Then you really have some ethical issues that you have to grapple with. And not everybody in your organization is going to be happy about it. So you have a board to keep happy and engaged, and employees who are in that organization often because they believe in the mission. And that's what makes it a little different than a company where you get your salary and you're working towards more salary. Here, the staff at EngenderHealth, we offered to do a spin-off at one point of a for-profit for some of the tech work that we were doing, and we couldn't get any of the employees to leave. They didn't want to work in a for-profit company. It's just it's a commitment that you make and a mindset that you take on, and meshing those two cultures is sometimes a little bit difficult. But I would tell you that when a foundation comes to you and says, I have $20 million to distribute and this is what I want done, you sometimes have to make some hard choices about either what to give up or whether that can coexist with your own strengths and your mission and vision. And you depend in that realm a lot on the political environment, which always influences who you are and what you do, and your own leadership. And that's why the people who run nonprofits have this incredible amount of responsibility, because they are the ones who ultimately have to pull their board along to change if the environment is changing. And often boards of nonprofits are volunteer boards and don't like change. They're happy where they are, and they're very risk averse, and they don't want to take chances. And so if you want your organization to grow and lead and change, then you have to have a strong voice and the backing of your entire organization. And so those positions are very important and very critical, I think, in the environment, and in particular today, where political leaders are actually looking more and more to those leaders for a voice rather than fighting with them. And that has to do with the current administration in the US, frankly. This just demonstrates, again, that kind of push and pull between your funding and your mission, your board, and your leadership in the directions that you want to go in. So how does EngenderHealth work? This is a picture of a maternity ward in Cambodia. And I remember walking into this, this little clinic. No, Vietnam. I'm sorry, Vietnam. I was thinking that wasn't Cambodia. I've kept this picture for years because I walked into this clinic and it was clear that women in the next room had been in this room and were delivering in the next room. They'd been moved out because we were visiting, and the floors had been scrubbed. And so I was very pushy about going next door because I could hear the women in the next room. And the women in the next room were lying on the floor, not much better than this, delivering, and were from the local community and were a select few who had come because of complications, not because they were having a normal delivery. But this is kind of the state of affairs. The question is always, when we look at how we do our work, how do we make a difference now? What can we do now? And then what are we looking for long term is a really important piece. But there are some things that you can change right away, and there are other things that have too many of these kind of issues floating around them to be able to impact right away. And so I always used to tell our group, what can you do now to this situation? So don't give that up. Don't sacrifice that for the long term while the government is coming, or the ministry wants this, or somebody else wants that, or gee, we're integrating. What can we do? Can we help them understand what their problem is? Now, I went to a clinic in a rural area in Kenya a long time ago, and my staff there took me because they wanted me to see what had happened. I hadn't really seen it beforehand. But what they explained to me was they went to this clinic that had no running water and was really just a bunch of rooms in a concrete building. And the staff there, who were very committed to doing good work, were waiting for the ministry to build a well so that when they got the well, then they could pump in water and they could have clean water to clean the maternity ward, which was horrible. They were cleaning it with buckets of water. And they had a very high maternal mortality infection rate because it was kind of a referral clinic. And they had a neonatal ward where the babies, the premature babies, were the only ones in there, and they all died because we went in and the babies were lined up 3 or 4 in one incubator that wasn't working. So they would put them in the incubator to keep them warm and close together so that they wouldn't get cold. And that was really the problem they had. So they had infection and temperature problems, clean water and temperature. And our group was there originally to implement a family planning service. And the group, when they were there, taught them this problem-solving methodology that we use called COPE, which is really just a piece of white paper on the wall that says, what's your problem, what's your solution, who's going to take care of it, and by when. And that's it. That's as much as anybody can deal with. And so the ministry falls off the chart because they're never coming. They're not going to come build you a well, and they're not going to give you a new incubator. So what are you going to do about it? So this group at the clinic, the staff at the clinic, got a little training in doing COPE and identified 2 problems while our team was there the first time, which was the water and the temperature problem. And when the group came back 6 months later, they had cut their neonatal mortality rate by 50%. And their maternal infection rate by 50%. And they had measured it before, and it was amazing what they had done with very little instruction. They built a well. They organized the community, they went on a march, they gathered the money, they dug a well. And so they had water, and when I was there, and I still get the chills when I think about this, they took me into the room in the clinic and turned on a water faucet. And that was what they had to show me. I was completely stunned. It had an incredible impact on their lives, on the community ownership issues. The community now owned the clinic. And they had in the neonatal ward, in the room that was the neonatal unit, they couldn't get incubators, so they took a closet, a mop closet in the side of the room, cleaned it, got a heater for the mop closet so they could heat the whole closet. And then they could line the babies up separated from each other. And the room stayed warm because it was a tiny little room, and they could do that. So they could keep this little gas heater going. So, you know, it's what can you do now? What makes you think that you can make a change? It's not always that small. It's not as small as the heater or the well. It can be a lot bigger. It can be HIV treatment, which is something for years nobody would consider. And if it weren't for a few radicals, still wouldn't be considering. So the job of the nonprofit sector is sometimes to think outside of the box and get a little radical in your own small civil society. So in describing EngenderHealth, I put on here a non-governmental organization because that's really what EngenderHealth is considered, and I think there's a point I've been trying to make all the way through this, which is that in theory, a non-governmental organization is an independent body and therefore should not be swayed by the likes of the politics in the government. But what has happened in the U.S. over many, many years, and is what makes us kind of, for better or for worse, unique, is the government is heavily invested in developing our civil society as a piece of democracy. So invested that they have bought it. And by buying it, which means they give so much money to it, they now own a piece of it, and therefore they have that independent voice that used to be completely in the civil society organization. And so when you hear about NGOs, you just have to think a little bit about what that really means, because it means something very different than the way we think about some of the other pieces of civil society. Now, originally one thought about civil society institutions as academia, more likely as activist groups that are independent and can make demands culturally. And community organizations and organizations of consumers or private voluntary organizations tend to be a little more independent because they're volunteers. But all of these groups in the US, of all of them, many of them get government funding now. And once you get, and it's a big decision for a nonprofit to take or not take government funding because of the power that the government then has over some of your decision making. And if the government happens to be on your side, great, you get a lot of money. But if the government changes and they have issues that they're trying, they have a platform that's different than yours, then you can end up in a lot of trouble. So this again goes back to the point that roughly half that budget is from the US government. And it's not just the US government, it's any large donor. Once a large donor owns enough of you, and they are transferring money either through you or directly to you as an implementing agency, and you can see down here that there are implementing partners locally, there are implementing agencies. EngenderHealth is considered an implementing agency. It's really kind of almost like a transfer agent, but provides technical support. So we actually have something we do other than just move the money through, but it's really a little higher up here than this. But by the time the money gets to the implementing partners on the ground, and they're the ones that have to make it all happen, they are highly influenced by not only the donor's agenda, but the nonprofit's agenda too. Some examples of how confusing this can be are with the gag rule. I mean, most of you know what the gag rule is, because every time we get in a president with a different agenda, it flips. The gag rule's instituted, the gag rule's kind of taken out of the picture, it gets put back in and taken out. And so we went from Clinton to Bush to Obama. You know, we're playing games here. Imagine what it's like to be on the ground in these countries and have to deal with the restrictions that are associated with those rules. So it's not just what the rule is, it's the fact that they flip-flop back and forth and everybody gets so scared that even when the restrictions are pulled away, many of those local communities still think the restrictions still exist. And by the time they catch up with it and how to transform their services, they're stuck with the potential of a new administration coming in. When we look at foreign countries, particularly developing countries, always say, oh, they changed the administration, the entire government changed, everything changed. It's not that different with foreign assistance in this country. A lot of things change when the administration changes. So the gag rule is one piece of this. The other piece that I think is really a lesson for us is the Pepfar funding, which is, as most of you know, kind of the President's emergency fund for AIDS relief, which was signed in 2003 and has been extended now by Obama, and the funding increased somewhat, although not that much. One of the few things that the Bush administration did in the social impact community that was really remarkable was Pepfar. But Pepfar, although he gave a huge amount of money to Pepfar, and in fact was great at pushing the agenda and getting the money out there, as opposed to some of the other very large donors and organizations that were doing HIV and AIDS work at the time. The U.S. did an incredible job in moving the money almost too quickly, so there were a lot of mistakes made. But also, there were restrictions on that money that were interpreted and reinterpreted and reinterpreted again over the years. And so the restrictions initially seemed horrible, related to some restrictions on working with prostitution and condom distribution around an abstinence-only message. You know, roughly half of the locally distributed money had to go for abstinence-only programs. These things changed as time went on, and then changed again after that. And so even if they weren't so bad and the restrictions got argued away, it's hard to change that on the ground. And so the bigger point here is the impact of where you get your money from, how you negotiate it with your board and your organization, how you negotiate it with your donors, and then how you implement it on the ground to make it clear to those who have less access to broad information and just need a clear message about what they can or can't do. And it means life or death for a lot of people, frankly. You know, if you're denying people abortion services and denying them access to post-abortion care, which is care after you've had a botched abortion, because you're afraid of the word abortion in your clinic setting, and your whole community is doing that, where's the woman going to go? So we're talking about, you know, accountable lives, either saved or not saved. Now, it's not always controversial, so I didn't want to give you that impression. So quickly, and am I out of time? No, I have 15 minutes. Okay. So I would like to run through quickly two issues that EngenderHealth in particular took on at an early stage and grappled with, and I will explain why and how they came out so that you know more specifically what kind of work they might be doing. So the two issues I picked were obstetric fistula and cervical cancer prevention. And I picked them because at the time that we started working on them, they were not very interesting issues in the world. But one of the great things about both of them was that they were non-controversial. They had nothing to do with abortion or family planning or even HIV and AIDS. And so there was a way to work on them that was a little bit different, and it still have a huge impact. And I would go back to do what you can do when you can do it, if you can do it, and don't put off all of those things that you could do, but something else is more in your face. So we started working on, I think I did cervical cancer first. We started working on cervical cancer prevention because in the very first year that the Gates Foundation was established, Mr. Gates, the senior, was running the organization out of his basement. And he was in Seattle, and so I happened to know him. And so when I heard that he was going to do this and was going to give away money, I called him up and said, gee, can I have lunch with you? It was that simple, believe me. And so I had lunch with him, and in the middle of lunch, he said to me, but Amy, you do family planning and contraception and sterilization, and, you know, Melinda's Catholic. We're not going to do it. It's not going to happen. I don't know enough, and he wasn't even sure that that was her position, but it turned out it wasn't her position. But he was just wanted to find things that were kind of clean. And so I said to him, okay, well, give me a week. I'll come back to you with something. I haven't given this, I walked away from this just forlorn. At that time, getting private money to work on something, we were talking about a large amount was $100,000. Okay, so, he was not dangling amounts. He didn't tell me how much to ask for, but I knew he had a lot of money. So I went back to my fearless executive team and said, give me 2 things that you really want to work on now, because we don't have a lot of time. And they put together a proposal to work on cervical cancer screening, and I'll explain why, and infection prevention strategies, because these were 2 things that were not direct. We didn't really have any money to work on them. So cervical cancer affects women in the same years of their life or after as female sterilization, right? So we knew the population of women who were getting cervical cancer. Although it usually hits women after the age of 50, in fact, in Africa and in developing countries, women get cervical cancer, invasive cervical cancer, a little bit earlier. And therefore, the problem is visible in the community when you go into the community. You can find women in the community who are dying a long, protracted death from locally invasive cervical cancer. And if you look at the numbers, you can see, that cervical cancer, it's really kind of right up there with developing country problems. There's not much we can do about breast, or couldn't at the time, but we knew we could do something about the cervix because the cervix is accessible, and we had had success in developed countries. When we looked at the numbers, we could also figure out that the death in some countries from cervical cancer was in fact equivalent to the rate of maternal mortality. The reason it wasn't of much interest is because it affects older women. And up until the AIDS epidemic, I would say older women were kind of recognized locally in the community as leaders, but otherwise not worth much of anything. And now, and in the last 10 years, older women in the community who have survived and not been infected are women who actually raise the children and run the community in many places. And so these women are particularly important. So when you look at them compared to the maternal mortality rates, you can make arguments both for the fact that the problem is dense enough, even though it doesn't look that dense, and important enough in the social transition. So there are about 250,000 deaths from cervical cancer that we know of a year. About 500,000 women report invasive cervical cancer. So this is just the flow of what we were dealing with when we first started looking at it. At the time, there was no simple technology for screening for cervical cancer. There were no Pap smears. They had programs, but nobody ever read the Pap smears. There was a bin in each clinic with these glass slides, and there were no cytopathologists. So the choices were primary or secondary prevention. Primary would have been a vaccine. We didn't have a vaccine yet, so we were going to look at secondary screening. We had to look at what the barriers were, create a different technology than the Pap smear, try and get a handle on the sociocultural norms around women having any kind of pelvic exam, what kind of infrastructure was needed. So we had, it's a bit like Mark reading off the Gates Foundation's proposal for a diagnostic platform. Something that doesn't need refrigeration, you can be illiterate, you can blah, blah, blah. There's a whole list of impossible, can't do. So we were challenged. However, the biggest challenge, I would say, was competing priorities on the ground. If you could come up with the technology, how are you going to get this implemented over something else? Because it was about women. Women, don't have the kind of stature that all the men running the country have often, and older women to boot. So we needed a cervical cancer prevention program that spanned generations if we were going to succeed, because we had to make an argument that this had implications for young and older women. And our argument was that the mother who comes in for her sterilization gets educated about cervical cancer screening and therefore understands how to help her daughter negotiate through prevention. Well, these are all kind of weak, basically. But we developed all of this, and then because of several years, I like to believe that because of several years of working on this and increasing the advocacy and visibility around the simpler technologies that we were coming up with and presenting the progress in our work, WHO began to get interested in the problem. They couldn't really ignore us anymore. And GSK and Merck announced that indeed they were ready to start talking about their early vaccine trials. And who would have thought that those vaccine trials progressed so rapidly that there was not even any possibility of a public-private partnership with the Gates Foundation so that we could assure a public sector cost for the vaccine, which is, if all of the disease is in developing countries, and it is for the most part, then if we don't negotiate a better price for the vaccine before it's ready to go to market, then we don't have that vaccine for the places where we need it the most. And that was the glitch in all of this. So the Gates Foundation, late in this, decided as it became clear that we were going to have a vaccine, the Gates Foundation got very interested in doing everything else around it and started to make large grants for further research and for involvement in planning for a rollout in developing countries for the vaccine, which was great. And the questions and challenges included, how do you introduce an adolescent vaccine when it's not part of a childhood vaccine program and not part of adult care? It's adolescents. And the big debate at WHO was, it's about sex. No, it's about cancer. It's about sex. No, it's about cancer. And this went on, you wouldn't believe it, adults arguing back and forth forever about where to house the vaccine work. Do we have to give messages about prevention and safe sex, given that the virus is endemic in the population? So the question is really, where does it rest? Who has control over it at WHO? And that actually determines a lot about what happens on the ground. On a practical level, the vaccine projects first needed or required a kind of exploration of the community understanding of cervical cancer, and then a timeline developed for planning, for doing the research needed through demonstration projects to figure out how to implement a program like this with adolescents. And those demonstration projects tested the kinds of things, the kinds of questions that we need to answer. Do you do it through a school system or through a school health program? Do you do it through a cervical cancer program? Do you do it through a reproductive health program? What's the clinical trial experience? Is it applicable in the same way in India as it is in Nigeria? What are the socio-cultural models? And so the grants were made to do 5 large demonstration projects running parallel to getting registration for the vaccines, trying to accelerate the introduction, getting the registration, getting it through the WHO approval processes, getting Gavi, so a lot of these larger organizations that control funding for vaccines to buy into the whole thing, and that takes years because there are competing priorities. So some of the questions, like I mentioned, were tailoring strategies to the needs of young girls. How do you maximize your coverage rate when it's 3 doses? It is a cold chain, which means the vaccine needs to be refrigerated. So where do they have a cold chain? How do you do that without wasting an expensive vaccine? And so the demonstration projects are now coming to fruition, and the results are great. They indicate that it's not that hard to vaccinate girls in school where there is school, that you have to have target programs that reach out to girls who are not in school, and in many countries at the age of 11 and 12, they're finished. They're not in school anymore. So you want a backup system, and those are more expensive to implement, so you save your pennies by being in the school or in a clinic, and where you bus all the schoolgirls to the clinic where the healthcare providers are. It's actually cheaper than paying per diem for a healthcare worker to go to the school, believe it or not, and doing outreach. And those results will lead to large amounts of donated vaccine by both Merck and GSK for startup programs and for disseminations to the countries that have experience and express an interest in it. And I'm not sure I have time for the, do you want me to talk about Fistula a little bit? The paradigm shift belongs to the cervical cancer piece because I think people have had to think very differently about that. Fistula is a huge problem that was hidden in the corner of villages till probably 10 years ago, maybe 15 now. Basically, the problem is that women in these countries, young women whose pelvis is poorly formed at an early age, and some older women who just have obstetric problems, obstructed labor because of the position of the baby or whatever, end up needing C-sections, can't get them in time, labor for days, and that's what this slide was about, and go on to deliver or be delivered of a dead infant and develop a hole from the pressure of the head and the pelvis on the bladder and occasionally on the rectum as a result of the delivery. And so there are large numbers of young women, very young women throughout Africa and Asia that leak urine, which is malodorous. They get abandoned by their families. They hide in the villages or are kept as a secret. They get abandoned by their husbands or their partners. And so it's very difficult to figure out what's going on with fistula in these countries, or it was when the problem was first uncovered. We used to have a lot of fistula in the U.S. Before C-sections were easily available, and so it's not an uncommon or or remote problem in the U.S. It wasn't that long ago. In order to figure out what this was about, we did a 9-country survey. That's the kind of work that EngenderHealth does. I'm kind of going to roll through how you go about solving this problem. We find out about the problem. We make a decision that we're going to do some work on it. We raise some money to fill in the empty spaces. We go get some data that's evidence. Then we have evidence to use with our donors to raise more money to argue the case for doing something. And we develop a strategy. So we did the surveys. We found out that it was a hidden problem. We knew that already. It was a problem being addressed by missionaries who did fabulous work, a bunch of surgeons who would travel from country to country, much the way they do facial repairs. And they would announce for a month in advance that there was going to be a surgeon there who would come and do as many cases as they could in a day or 2 or 3. And then the problem was that the hospital had to take care of them post-op because it's not like you fix it and they go away. You really have to have the woman control. You have to have bladder control for a week to 2 weeks. Nobody really knew how long. So you have to define the problem. You have to find the people who've been solving it and try to work with them, which was a great opportunity to mesh the kind of terrific work that the religious groups have been doing with a more global or public health agenda that is distinct from a religious kind of go in, go out thing. And one of the problems, frankly, with the missionary work was they didn't talk about family planning with it and really encouraged girls to go out and get pregnant again and come back for a C-section. And it was a little disruptive when we started working on a large scale. We had to figure out how to invest in emergency contraception, which means building the capability to do C-sections as a solution to the root problem. Even bigger than that, of course, is the problem of early marriage or early rape and pregnancy or however it happens. And so that was way up here on the scale of things we could get done. Way down on a practical level was trying to devise in places where there were target areas of high levels of problems a system for training up capacity to take care of it instead of flying in and flying out. We train by, mentoring and training teams of people. So you go in, you train a group of people, they work, you come back, train them again as trainers. And then they become the trainers for a larger group of people in country, and they're the local folks. Some countries don't have enough doctors to do this, and that's a problem. And one of the questions will be, one of the questions and approaches to this now is to train mid-level clinicians to do C-sections. Finally, after many, many years of arguing about doing that. And it's clear that surgery can be done if you apprentice with somebody, which is how it was done forever before. So it's in all the refugee camps, all the people that do surgery in the refugee camps are all non-professional trained individual, professional, non-professionals. This is the kind of gold standard fistula hospital in Ethiopia. I was really impressed, but it's really a showcase. No other fistula hospital I've ever been in looks like this. They look more like the room with the wood boards on the bed, and they're classed up a little bit from that. But the Addis Hospital got so much press at the beginning of the fistula campaigns that they kind of classed up to something very beautiful. And one would wish that they would be, because these women are there for a long time. So the global recommendations were advocating for laws preventing early marriage, obviously addressing the gender and power issues, the constraints on getting to a provider for a C-section and then having the money to pay them to do it if there is a provider. Transportation is part of emergency obstetric care, and it's as big a cause as anything for the problems with fistula. And then considering the economic and education schemes for women who've had fistula and have been completely abandoned. And that's kind of a third level and something that I think we looked at proactively, and I'm glad we did because it's played a huge role in advocating with governments for providing the services. And that's the close of my talk. And since this is Chicago, I thought I would, give you something familiar over the slums. So thank you very much for letting me introduce you to EngenderHealth. Endangered health. In that case, it would have been endangered health. No, we were not in China at the time, and there were large non-voluntary sterilization programs in lots of places, and our work was actually, we got paid to come in and transform them into voluntary programs. I think there was a lack of consciousness about women's rights at all in many places, and the programs were really not good.
How do you approach to the community saying one of our recommendations is for the girls to start to, not marry this young? How do you approach that? I mean, you talk about women's rights, but how do the community do this?
I think that there's a lot going on in this area. Not unlike if you go back to FGM, it's a little bit like that. When we're dealing with mutilation. You have to develop a community advocacy group, a women's advocacy group, and there are organizations that do that. Our work is in service delivery, and so we provided the evidence or the arguments for why one would do that, but the advocacy organizations are the ones that work specifically in communities to develop a voice in the community for their rights. And so FGM was a completely village-based movement where folks went to the village elders who were men and argued for not having their daughters circumcised. And it developed over years through a literacy program. It started in a literacy program. So that's about as much as I can tell you. I think that there are reasons, there are ways to develop reasons for delaying marriage that are starting to take hold in a lot of places that would surprise everyone. There are big approaches in some of the HIV endemic countries where the drive is really not just avoiding early marriage, but avoiding exposure, so that the messages go hand in hand.
So they don't see like a foreign imposition or a foreign plan, and we don't want you to, we want to change your way of living.
I think that's why most of those are locally run groups. They're not expats. They're not foreigners. They come in, and the foreigners may come in and provide support when they're asked for it. But it's really local groups in the country. Like South Africa has an entire network of women's community leaders who run it themselves. And they may come for support or information. With the internet now, they actually have access to a lot of services and support. It's completely changing, and it will continue that way because of communications.
Sure. I think this is incredible work that you're doing, and I want to thank you for that. But
vaccine is effective in anybody, no matter what their age is, as long as they haven't been exposed to the virus.
So they've been exposed.
So if they're sexually, the goal is to get the vaccine before you're sexually active, and since girls don't often disclose that information, you look at when you're determining it in the country, and the country is making a recommendation nationally for the standards, and we have standards here. The recommendation is 9 to 15 or something, 9 to 14. So you can get it after that age, but if you've been sexually active, the chances are that you've been exposed to one or more of the viruses. It's that endemic. And so your goal, if you really want to change the face of this disease, is to vaccinate the girls beforehand. And we still don't know how long the vaccine is good for. We know that it's at least 5. Some of the studies are showing 7 now. We'll have data on 10-year immunogenicity soon. And at that point, we'll start looking at whether boosters are necessary or not. But who knows? It's a great vaccine. It's a very, very immunogenic vaccine.
I love your story about your early interactions with the Gates Foundation. Because Fistula and Hpv have been having more recent interactions.
Yeah, it's a whole different ballgame, I'm afraid.
Well, I want to agree with Shola. I mean, the work that you've described in EngenderHealth and your 50 years of involvement is really quite extraordinary. There was one slide I just have to tell you that struck home. And that was your slide in the 1857 Women's Hospital.
The Fistula Hospital.
I was born there. I was born.
1856.
We want to ask Mark. Let me just tell you one other thing that I think that you asked about before. I left EngenderHealth. I didn't stay forever. I don't think people should leave nonprofits for too long because it's incredibly hard work. And you stop doing it well because you burn bridges and build bridges, and by the end of 10 years or 15 years, you kind of have too many people you owe debts to. So I left and went into the private sector to work on technologies because that's brain-wise much easier for me. I didn't have to think about anything other than, how to make this a better widget. And I'm now, involved in raising a global health venture fund that we will raise money to invest in seed companies and startups that do predominantly women's, but general health, that have a business plan that involves commercializing, taking the product to the developing country markets. So they will have to be appropriate for that market before we invest in them, even though they may have an application here. And there are some unbelievable opportunities right now to do things. So I think Gates also is trying to take advantage of that opportunity. There are a lot of seed small companies that haven't been able to find money to do their work. So you all have a future in all kinds of things if you're interested in global health. There are all different directions to go in. So.
Thank you so much. Wonderful.